Welcome, everyone. I'm Steve Chapter, and I'm the director of CHIPS.
I'm on a conference call.
Yeah. So it's great to see everyone here. We've had, because of COVID, we've had
Dr. Chapter, you're muted.
Okay, super. All right, well, we're out of practice, folks. It's been a year and a half since we've had HIV Grand Rounds, so please forgive some of the mistakes we're going to make today, but we're super excited to be back in the business and to have science being highlighted on HIV and HIV prevention, and HIV treatment. We are super excited also to have this kickoff led by Dr. Raphael Landovitz. Those of you who know Rafi know that he is today going to be talking about long-acting injectable Cabotegravir for HIV PrEP, what we need to know and what we know and what we need to know. Those of you who know Rafi know that he led the largest trial of long-acting injectable Cabotegravir for HIV prevention, a 4,500 patient trial across many countries in the world. He is our professor of medicine here in the Division of Infectious Diseases. He is at the UCLA Center for Clinical AIDS Research and Education, or the CARE Clinic. He's the director there. He's the co-director of CHIPS. He's led combination prevention studies using all kinds of medications and behavior therapies for post-exposure prophylaxis and pre-exposure prophylaxis. He's part of the leadership groups of DAIDS-funded ACTG, the HIV Prevention Trials Network, and the former Adolescent Trials Network. He recently completed term as a chair of the ACTG Antiretroviral Strategies Scientific Committee, and is the principal investigator of 2 multi-site PrEP demonstration projects in Los Angeles County. He leads the NIH DAIDS-funded phase 2 and phase 3 registrational clinical trials evaluating long-acting injectable Cabotegravir for PrEP. He's on the executive committee for the HPTN and was awarded the HIV Research Award in 2017. I have the distinct honor and pleasure of introducing my friend Rafi. He'll be talking with us about Cabotegravir as HIV prevention. I want to remind everyone to stay muted, post questions in the chat as we're going along. And without further ado, Rafi, you're on. It's great to see you.
Thank you, Steve. And thanks everyone for joining. That was quite an introduction. I'm not sure I deserve any of that, but thanks for joining anyway. Today I'm going to be sharing the results of HPTN 083 and putting it into context a little bit with the current PrEP landscape. Some of you may have heard some of these presentations before. We presented some of these data at the AIDS 2020 conference last summer, and then some additional follow-up data that was presented at CROI this past year that further informed the pharmacokinetics and resistance profiles and further laid plain some of the thoughts about why some of the PrEP breakthroughs that happened in the Cabotegravir arm happened, and really gives us some insight onto what we need for implementation and moving this forward. And I hope this presentation is going to be useful to those of you who are thinking about local studies that would implement or consider the implementation of Cabotegravir as PrEP as soon as it gets regulatory approvals, because some of this nuance is really important for implementation and is going to represent a departure from the way we've thought about PrEP implementation and the testing that has to happen around it before. So hopefully it'll be useful. And maybe I'll be able to advance my slides. How long in the epidemic are we? And we still have Zoom problems. Anyway, these are my disclosures. This is what I'm going to talk about today. I'm going to try and be brief. Those of you who know me know that's not my strong suit. So here we go. I'm going to give you a little bit of PrEP background and context in which 083 happened. I'll tell you a little bit about the Oa3 study design, very briefly what the statistical methods were that caused some confusion when we first presented the results last May. And then we'll go through what the results were, who the population were. Steve already mentioned that we enrolled 4,570 participants in the study, what the HIV incidence rates were in each arm, some safety considerations, and then the seroconversion events, some other clinical outcomes of interest, and then sort of the meat of what we presented at CROI, which is it's a lot of science, but it's super interesting, and I hope you'll agree with me when we're done. Anyway, many of you have seen this graphic that I used before. It's my way of summarizing the available randomized data on oral TDF FTC for PrEP. And the conceit here is, I grew up in the Northeast of the United States, and around Christmas time in the Northeast, churches, bazaar, and synagogues and mosques, they do fundraising to help support some of the charities that they contribute to, and they put a big thermometer outside the place of worship, and as they fundraise, they fill up the thermometer to show how close they are to the goal. And I sort of appropriated that idea here. The character is designed to reference the population at risk based on sex at birth, and then how full the character is represents the point estimate of the placebo-controlled or no intervention controlled efficacy of TDF FTC PrEP or TDF PrEP in each study. And you can see that there's a wide variety of results across this. And of course, what we've learned from all of these results is, number one, PrEP doesn't work if you don't take it. That's not a surprise to anyone. And there's more forgiveness for oral PrEP dosing for rectal exposures than for vaginal exposures. And that probably has to do with the fact that the chemical components of TDF FTC PrEP get into cervicovaginal tissues about 100-fold lower than they do into rectal tissues, leading to less forgiveness. Some of you are wondering why there's a mime in the lower right corner. That's not intended to be a mime. It's just the Hypergay study done in France and Quebec. That's why there's a beret there. Looked at on-demand or pericoital dosing of TDF FTC, and that's what the stripes are supposed to indicate. So not daily dosing, but pericoital dosing in a 2-1-1 pattern that we can talk more about later, was shown to be highly effective also. We then expanded our concept of PrEP to really PrEP 2.0 as we got some other effective interventions through some additional studies. Many of you heard of the dapivirine ring. It's a vaginal ring that dispenses a non-nucleoside reverse transcriptase inhibitor called dapivirine that's not available as a pill. And it was about 30% effective in the original randomized placebo-controlled trials. Open label extensions against a counterfactual placebo have suggested 50 to 70% efficacy. And the dapivirine ring was recently granted regulatory approvals in Europe by the European Medicines Agency and is currently before the US FDA. And then I think everyone's aware that a Gilead-sponsored trial looking at a drug called Descovy or TAF FTC was compared head-to-head to Truvada or TDF FTC in gay men and transgender women and showed that they basically worked similarly well. So that's sort of what some people were considering PrEP 2.0. And it was in that context that we designed HPTN 083, which was designed to look at long-acting injectable cabotegravir compared to TDF FTC, because it wouldn't be ethical anymore to do a placebo-controlled trial now that we have effective interventions for HIV prevention. And it was a phase 2b, 3 randomized double-blind, double-dummy study that, as Steve mentioned or alluded to, we did it at 43 sites in 7 countries globally. I'll show you where that was in just a second. We enrolled cisgender men and transgender women aged 18 and above who were at increased risk for HIV acquisition. That was sort of defined based on that second bullet there on the slide. They were generally in good health. They didn't have active Hep B or Hep C. And they could take these injections that had to be given in the gluteal region. And that meant that we had to exclude people who had gluteal implants or fillers, because as you can imagine, if you have either a saline or a silicone implant in your buttocks and then you try and inject something in it, that's a risk, right? Because you could pop the implant, so it wouldn't be safe to do so. We had originally planned that we were going to enroll 5,000 people. And because if you look at the oral PrEP experience, what you see is basically young people, especially young MSM of color, and transgender women are the groups that not only are disproportionately affected by HIV, but were benefiting the least from oral PrEP interventions when you looked at uptake and reductions in population level incidence. So we had pre-specified that we wanted to enroll at least half of our study population from the group of people who are under the age of 30. At least 10% of the population would be transgender women, and at least half of the US enrollment would self-identify as Black or African American, again, to see if we could improve PrEP options for these groups that weren't seeing the population level benefits from the currently available options, and would make us able to make some statements about those subpopulations in this study. Our primary efficacy endpoint was incident HIV infections in the blinded study comparison, and we had a co-primary safety endpoint. These are the sites where we did the study. There are 26 sites in the United States. There are 5 sites in Peru, 2 in Argentina, 4 in Brazil, 1 in South Africa, 3 in Thailand, and 1 in Vietnam. And that's where the study was conducted. These are NIH-funded sites. Some of you are wondering why there isn't anything in Europe, and that's because the NIH, for a variety of regulatory and logistic reasons, just has a really hard time partnering with Europe. So that's why that's the case. So this is our study design. It's a little bit complicated, so I'm going to ask you to give me 2 minutes to just go through this. So people who were eligible for the study got randomized 1-to-1 to either the top half of the slide or the bottom half of the slide, orange or blue. And everything I say about orange is in this presentation is going to be the Cabotegravir arm. So these people get randomized, and it's a 3-step study. And in the first step, if you look at step 1 there, people got a Cabotegravir pill, and they took that pill every day. And while they were taking the Cabotegravir pill every day, they also took a Truvada placebo every day. So everyone got 2 pills a day. And the reason we did that is the long-acting injectable Cabotegravir, once you inject it in someone's body, you can't take it out, and it lasts for a year or more. So if someone's going to get a rash or a side effect or something serious from that, you don't want to just give them an injection right away. You want to make sure that there's some belief that you have that they're going to be able to tolerate it, because once you've given it, you can't take it. So it turns out that Cabotegravir is available in a short-acting daily pill also. That obviously doesn't give you the adherence advantage of a shot, but you can do it. And so we gave people the Cabotegravir pill for 5 weeks before we gave them any injections, because if they tolerate the pill version, where if there's a side effect, you could stop it and it gets out of the body quickly, then you have at least more confidence that it's going to be safe to give them the injection. If they tolerated it safely, then they moved to what's called step 2, which is the direct injectable oral comparison, where they were getting active Cabotegravir, now injections, every 8 weeks after the first 2 were separated by just a month, and they continued to take a Truvada placebo. Don't look at step 3 for a second, flip down to the blue half of the screen on the bottom. Okay, so the people who, again, 1-to-1 were randomized to the Truvada arm, they were taking 2 pills a day for the first 5 weeks oral also. But what's different here is that the Cabotegravir pill was a placebo, and the Truvada pill is real all throughout this arm. So people are getting the sort of the standard of care PrEP at this point. They're getting Truvada, right? And then when they flip to the injectable part, that's step 2, they're getting a fake injection. It's a feeding solution called intralipid that looks and viscosity-wise is exactly the same as the Cabotegravir, and we gave them continued Truvada at the same time. So they were really on Truvada PrEP. They just didn't know which one they were on. Step 3, the goal of that on the right side of the slide, is because Cabotegravir lasts in your body for a year or more when you stop it. Anybody who stopped the injections early, we gave them a year of just straight up Truvada, no placebos, no guessing. You knew what you were getting, just to give them adequate protection while that Cabotegravir is washing out of their bodies. So I hope that study design makes sense. It's a little complicated. You can imagine that it was a fairly big lift to make sure that participants understood everything that they were signing up for. And it was, and we had some great graphics and pictures that help people understand that. So I'm not going to spend a lot of time on this, but I know we do have some of our methods people on the call today. And so I did want to just talk a tiny bit about the statistical design. This was pre-specified as a non-inferiority study design, and the non-inferiority margin was 1.23, meaning a 23% relative non-inferiority margin. We had an alternative hypothesis of 0.75, which means that before the study started, we guessed that cabotegravir was going to be 25% better than Truvada for HIV prevention. We were targeting a population with a background HIV incidence of about 4.5%, and we were guessing, and this was a guess, that the adherence as measured by plasma tenofovir being detectable in people's samples in the Truvada arm was going to be about 57%. The study was originally designed that it would stop when there were 172 people who got HIV in the entire study. And we were actually terrified by that number from our statisticians, because that's more people getting HIV than had been seen in any of the previous Truvada trials all put together. So that's a lot of people getting HIV. And you, of course, don't want to see people getting HIV, but in order to get a result that would be interpretable when you have a really highly effective product like Truvada, that's what had to have happened. And there were pre-specified interim analyses when a quarter, a half, and 3/4 of those endpoints had accrued. I'll spare you all the drama, and it was drama. And those of you who know me at all know that I love the Broadway musical Hamilton. And those of you who know the Broadway musical Hamilton know that, you know, at the Battle of Yorktown, you know, when the Americans ultimately defeat the British, there's a recurring line in the song Yorktown in the musical Hamilton, where they keep saying, "The world turned upside down." And for me, that was May 14th, 2020. That was when the DSMB met for the first time to do a pre-specified analysis, because we had 1/4 of the planned 172 events had happened in our study. We've been in the field since 2016. We're 4 years in, and we only have 25% of the endpoints. And everyone said to me, "Do you think the DSMB is going to stop the study?" And I said, "No way, no way, no way, no way." And it shows what I know, because the DSMB stopped the study because cabotegravir was not only non-inferior to Truvada, it was superior to Truvada. And so now I'm going to tell you the rest of that story. So this is the participants that we enrolled when they had stopped the study. They had enrolled 4,570 participants. You can see how they were broken down between the two randomization arms. So we had a primary intent to treat population. And again, my methods colleagues will appreciate why that's important. It turns out 5 of those participants had actually been enrolled in the study unknowingly at the sites, already infected with HIV. So they were in the eclipse or window period when they were enrolled. And so they were left out of that, that initial analysis. And we had a primary efficacy cohort that also excluded an additional 71 people who never came back for any follow-up. So we don't have any data on their HIV status. You can see the overall retention in each arm out to 2 years on study. About 3/4 of the participants were retained at that time point. So these were our study participants. You'll remember, and again, the cabotegravir is in orange and the Truvada arm is in blue. We had pre-specified that we wanted at least 10% of our population to be transgender women. We actually enrolled 12.4%, so we were really happy that we had exceeded that. We wish we could have done even better. And I think if this had been a study that was specifically designed by, about, and for trans individuals, we would have done better. But you know, as many of you know, there's a tendency to include transgender individuals in MSM studies, which probably is no longer appropriate to be doing. Not that it ever was, and we're moving away from that happily. But that we were able to enroll 12.4% of our population transgender individuals. We had pre-specified that 50% would be under the age of 30. In fact, fully 2/3 were. A lot of people ask me, you know, the NIH definition of adolescence is 13 to 24. We enrolled 18 and up, so I can't tell you about the under 18 group. But in terms of our population that was under the age of 25, so 18 to 24, it was 40% of our population that met the NIH definition of adolescence. That's important for a reason I'll come back to later. And within the US, we had said we wanted 50% of our enrollment to self-identify as Black or African American, and we just hit that metric. So we were very happy about that. So I just want to show you really quickly by region what the metrics were in the US. We enrolled 1,700 people. The mean age was 27, 60% were under 30. Transgender enrollment in the US was about 7.5%. And as I mentioned, 50% were Black or African American in the US. In Latin America, which was Peru, Argentina, and Brazil, we enrolled just about 2,000 people, so 43% of our overall enrollment. Median age was 26, 2/3 were under the age of 30, and 10% of the population were trans. In South Africa, we only had one site, so they enrolled 152 participants, but they were super young, as you can see, and I was really interested in seeing this. 10% of the South African enrollment were transgender, and I think we don't often acknowledge that it's going to be feasible to enroll MSM and transgender individuals in our sub-Saharan African partner regions, but it is possible, and I think we need to remember that. And the incidence rates are kind of staggering in those populations, so it's really important that we have interventions that are going to be implementable in those populations as well, and discreet to avoid the complications of being identified as MSM or trans in nations where behavior or even identifying is criminalized. In Asia, we had 16.5% of our enrollment from there. Median age is 24. 80% were under the age of 30, but check this out. 30% of the enrollment from our Asian sites were transgender individuals. So that was really exciting. And they have tremendous relationships with their transgender communities, particularly in Thailand and Vietnam. So it was really gratifying to see that collaboration over time lead to really successful enrollment. So these are the primary results that we presented at AIDS 2020. And I say that because I'm going to show you some updated results a little later. So I'm going to ask you to kind of photograph this in your mind. So if you look in the lower left hand side of this slide, in the Cabotegravir arm, again, in orange, we found 13 incident infections. So the incidence rate was 0.41 per 100 person years. And in the Truvada arm, there was 39 incident infections. So 3 times the number, if you want to just be very granular about it, with an incidence rate of 1.22 per 100 person years. And then if you flip over to the right, you'll see that the hazard ratio favoring Cabotegravir, it was 0.34 with robust confidence intervals. So that's a 66% reduction in the incidence rate in those people randomized to Cabotegravir compared to Truvada. And you can see it excludes our pre-specified non-inferiority margin, as well as the superiority bound, as well as our pre-specified alternative hypothesis of 0.75. So that was a superiority result. A lot of people ask me, so what was the number needed to treat? How many people would you have to give Cabotegravir as opposed to Truvada to prevent one additional infection? So here's a back of the envelope about that. The number is 123. And remember, that's compared to Truvada. That's not compared to doing nothing. That's really important. This is the Kaplan-Meier curve for the methods folks who like to see these things, showing the highly statistically significant hazard ratio of 0.34 between the two agents, as well as the number of participants at risk at every time point. A lot of people ask me about how this broke down in between the key populations. And you can see when you broke it down to people over or under 30, whether it was the transgender women or the cisgender men, whether it was the Black or non-Black populations in the US or by region. This wasn't powered for this, so you should not take the crossing of one as meaningful in these cases, but the directionality and general magnitude of the effect was consistent across all of these subpopulations. So this is the slide that I presented at AIDS 2020 last year that got a lot of attention. So with your blessing, I'm going to take a minute and go through it here. I gave letters and numbers to each of the cases that happened in the Cabotegravir arm. These are the breakthrough infections. And I want to take a minute and explain to you why I think each of these breakthrough infections happen, because I think it's really important. To some extent, these are unicorn events. They're really infrequent events, but what that does is it gives us an opportunity to say why in each case and try and understand why Cabotegravir didn't work in each of these cases. So the first one I want to show you are these A cases, A1 and A2. And these are the cases that actually were living with HIV before they got any PrEP in this study. So they were in the eclipse or window period. So the regular HIV testing that was done at the sites didn't find these people as living with HIV, but they were infected. I'll tell you how I know that in a minute. But because they weren't detected as being living with HIV when they went into the study, they actually got exposed to cabotegravir. The purple is the oral lead-in, that's step one I told you about, and the orange are the injections. That's what the little syringes mean. The hatched orange lines mean someone was late for an injection. The blue is when they were given Truvada in that step 3 oral tail. And the green emoji, the green virus emoji, is when the site actually, the green emoji is actually when the infection happened. What I'm going to show you later are some asterisks that will show you when the site found the HIV infection. So the answer to why A1 and A2 broke through is they didn't break through. They were actually had HIV before they ever got any study product. So we don't need to say anything else about this. The B cases, and there are 5 of them here, are in my mind easy to understand because they basically happened a long time after anybody took any PrEP, right? You don't take PrEP, it can't work. Not a surprise to anybody who's listening to this talk, right? So all 5 of these cases were diagnosed a very long time after anybody got anything orange on this slide. You can see that, right? The orange virus emoji is very far away from any orange, right? Now, some of you are going to say quite rightly, but look at B4, that's close to some blue. Shouldn't they have been getting Truvada? Sure, but they weren't taking the Truvada. So again, don't take it, not going to get PrEP protection. Hope that makes sense. So to me, those were easy to understand. C1 to C3 are really important because these were 3 people who acquired HIV during that oral lead-in of the Cabotegravir. Now, a couple things, right? We know when you start Truvada PrEP, you don't get instantaneous protection the very first day you start it. There's a time to onset of protection. So you wouldn't be shocked if Cabotegravir also had an onset to protection. So that could be what we're seeing here. The other thing is you're enrolling people in this study who who don't want to take oral PrEP, right? They're enrolling in the study because they want an injectable product because they think that's going to be better for them. But you're still asking them for safety reasons to take an oral product for a month. Maybe they weren't actually taking the oral product. So maybe that oral lead-in, even though we're trying to use it for safety, it's turning out to be a liability in terms of vulnerability to HIV. So that's important to keep in mind. I'll tell you more about that later. And then these 5 cases were the ones that got the most attention because as far as we can tell, these are people who were getting on-time injections, but they got HIV anyway. So what's up with that? Really important. So I will, before I come back to the answer to that question, I just want to tell you that, here we have the Truvada infections that happened, and there were 39 incident infections. And then here at the bottom, there were 3 E40 to E42 that actually were in that window period also. And so they had HIV before they were exposed to any PrEP product. So it didn't just happen in the Cabotegravir arm, it happened in the Truvada arm also. And when we did the blood levels to see how well people were taking it, I'll tell you the punchline right now that 37 of the 39 people weren't taking their Truvada, and that's why they got infection. The other 2, one of them probably got exposed to resistant virus, and that's why they got it on Truvada. And the other one, I can't tell you exactly why it happened, but that's the punchline. Okay. A lot of people say to me, okay, if you tell me Cabotegravir is 66% better than Truvada, and you also tell me that how well Truvada works is dependent on how much people took it. And you remember at the beginning, I told you that we guessed that adherence in this study would be about 57%. Now I'm showing you here what the actual adherence to the pills were in this study. And the comparable number I want you to look at is in this box all the way over on the right side of the slide. You see where it says plasma TFV? That number, that 87%, That was the number that we guessed would be 57% in our study design. So we were wrong. People took Truvada much better than we thought they were going to in the study design. All the pretty colors over on the left, those are the dried blood spots. It's more granular adherence data. But the one that we had actually powered it on statistically is that plasma tenofovir level detectable, which is greater than 0.3. So what that means, and we know Truvada works better the better you take it, that Truvada performed better in this study than we thought it was going to, and still Cabotegravir was superior to it. So the take-home message that we're going to get to at the end is not that Truvada is bad. Truvada is really good. It works really well if you take it. What's really impressive is that even with people taking it really well, Cabotegravir did better. And to me, what that means is not Cabotegravir is intrinsically a better compound, a better drug product. It's just that when you give it to somebody as an injection and they don't have to take pills every day, it makes it easier to provide PrEP that covers their sex acts. That's my interpretation of the data. You can tell me at the end if you agree with me, if you believe it. Okay, some people said, okay, well, people took the Truvada better than you thought. Is that true in all populations? And so here are the data broken out again by region. That's the first set of 4 bars on the left side on the bottom after overall, and then broken down in the US by Black versus non-Black, and then in the gray bars by age, and then all the way on the right from our transgender women versus our cisgender men. And what you can see is similar to what we saw in other PrEP projects, which is the younger people a little bit, our transgender participants, and our African-American US participants have greater challenges to seeing the benefit from oral PrEP. And that was true in our study also. But what's really impressive is the Cabotegravir benefit was sustained and similar across all these populations, even as the Truvada adherence went down. I hope that makes sense to people. Okay, trying to move forward. Maybe. Okay. Side effects. What were the differences in the side effects? So this has got pretty colors on it. And what this means is these are injection site reactions. This was basically the only side effect that was different significantly between the Truvada and the Cabotegravir arms. You give somebody a 3 milliliter injection in their butt, some people are going to find that painful. And if you see all the way over on the left side of the slide, basically 80% of people in the Cabotegravir arm had some reaction, some pain, tenderness, swelling at the injection site. But if you look at the hatched line that's right with it, 30% of people who were getting the placebo injection also had some pain at that injection site. Then if you move to the right side of the dotted black line, you can see that the reports of the pain actually went down over time. So basically, if you tolerated it up front and you sort of got through those first couple of injections, the likelihood that you were going to continue to have pain went down over time. And what the colors mean is how severe it is. So the green ones are mild ones, the yellow ones are moderate, and the red ones were severe. I will tell you that if you got a severe reaction to this from the injection, you are much more likely to stop taking the injectable product. And that makes sense, right? I mean, who wants a painful intervention that they thought was pretty severe, right? And I'll tell you, at our site, we did this study, and Steve can tell you also, his site did this study also. There are some people who just don't tolerate injections well. And they're like, yeah, that was horrible, and you're never doing that to me again. But happily, that was a really small number of people. It turned out it was about 2.2% of the people who were in the Cabotegravir arm of this study said, yeah, that was so bad, I don't want that anymore. And I think that's going to be true of any product. It's not going to be for everyone. This isn't going to be a magic bullet. Injections aren't going to be for some people. I will tell you that this was more common in the United States than elsewhere. And it's very interesting because what we've heard in some qualitative work that we've done and from other community partners is that in sub-Saharan Africa and parts of Asia and Latin America, the thought is that injectable medicines are the best medicines, and that actually you haven't gotten good treatment until you've gotten a shot of something. So this culturally, there's a very different paradigm for what's considered good medicine and effective and what people want. That's different regionally that I think is going to really be important to know about in terms of implementation. So this is just a list of other adverse events in terms of what was different between the arms. I will tell you that there was more kidney problems in the Truvada arm, not a surprise. People had more runny noses in the Cabotegravir arm. I don't know what that's about. And there was an interesting finding of more sugar elevations in the Cabotegravir arm. And again, we have to follow up on that. I'm not sure what that's about. So in terms of deaths, there was no difference between the arms, and in terms of severe adverse events, it wasn't different between the arms. So I think that's important to know. So some people have said to me, so those are really low HIV incidence rates in both arms. How do you know that the people in the study were ongoingly at risk? And I would point to these data. So this is, in the top half of the slide is prevalent bacterial STIs at baseline, so when they came into the study. And then on the bottom half of the slide is incidence rates of these bacterial STIs. And so this is pretty impressive. It's the syphilis incidence rate. And I will tell you for, Roger Deedles is going to throw me under the bus about this, so I'll just say it up front. Yes, we centrally adjudicated every syphilis titer that happened in this study. We drove the sites absolutely bonkers and they hated us. Steve can speak for his site. They were ready to throw darts at my head. But we centrally adjudicated every syphilis test that was done in this entire study. So yes, I believe that number, Roger. 16.5 per 100 person years. And for rectal gonorrhea and chlamydia, it was over 27 per 100 person years. So I do believe that these people were ongoingly at risk. So I believe that both these drugs work well. Some people have asked me, and I'm not going to spend a lot of time on this today, about weight gain. Those of you who study HIV treatment know that integrase inhibitors has been associated with weight gain more than other antiretrovirals. So we did look at that in HPTN 083, and I will tell you that overall, yes, the people in the Cabotegravir arm did gain more weight, 1.3 kilograms per year compared to 0.3 kilograms per year, so about a kilogram more per year of weight gain in the people who got Cabotegravir. So, to the layperson, does Cabotegravir make you fat? You might think that from this, but it turns out it's actually driven by the first year. In the first year, you actually gain 2 kilograms of weight more on Cabotegravir compared to Truvada. And after that, after the first year, it's identical. Everybody's getting fatter, which you all probably knew because I know in the last year, I've gotten the COVID-19. How about you? So, I think we're all getting heavier, and yeah, it's not different between the arms after the first year. And I would argue to you that probably that difference in the first year isn't because Cabotegravir actually makes you gain more weight. It's because Truvada gives you nausea and stomach upset and makes you eat less in the first year. That's my hypothesis. Anyway, so those results were what we presented last year. And then we figured out something. So these were the results that we first presented. You'll remember this and the hazard ratio and all that. So what I didn't tell you a lot about was the HIV testing that we did in this study. So on the left side of the screen, you can see what we did in real time. So before we put anybody in this study, we did a viral load, we did a 4th generation test, and we did a point of care test. And after that, we did a point of care test and a 4th generation test at every visit. And then we stored samples. And then we went back at the end of the study, and in the central lab at Johns Hopkins, we did all sorts of crazy, super sensitive viral load based tests. And what we found out is that Cabotegravir delays the reactivity of your conventional HIV testing assays. And so we did some additional testing, which was post hoc. It wasn't specified. We basically used viral load testing, qualitative and quantitative. And if people have questions about that, we can get into it in the question period because I don't want to bore everybody who's not into the lab stuff. But we basically did some extra testing and it changed some stuff. So remember this diagram that I showed you? I'm going to ask you to keep your eye on cases D2 and D5 that I've circled in red here. And when we went back and we did this more sensitive viral load-based testing, watch this. Did you see those emojis get big and move to the left? So D2 moved earlier, and you could say, who cares? But look what happened to D5. We had evidence that D5 actually was infected before they ever got any PrEP product at all. So D5 really isn't one of our D cases, is it? It's an A case. So we now only have 4 D cases and 3 A cases. But when we did that more sensitive testing, we also found another A case. So it turned out we had 12 incident infections, not 13, and 4 baseline infections, not 2. And you might say, okay, that's nice. So what? Well, so what is it changes, it changes our incidence estimate in the Cabotegravir arm. None of the Truvada cases changed. So this is something that is fairly unique to Cabotegravir, that it delays the turning positive of these conventional HIV tests. And the interpretation of the benefit really didn't change. It went from 66% better to 68% better. I mean, who cares? Potato, potato, you know, it's still superior. But I'm going to show you just really quickly some important data about what these delays did and what it means for resistance. And this is really important. So these are, and again, these are unicorn cases. So I'm going to get a little bit in the weeds here to tell you about each one of these cases. Okay, these are the 4 A cases. And just to orient you, look up here at case A1, just so I can tell you what you're looking at, right? So these orange dots, these are the blood levels of Cabotegravir that we measured at each of the study visits. What you want to see is you want to see it above this 1.33 line here. That's the target that we really wanted to be at, okay? What this blue line is, that's when the site HIV testing algorithm turned positive. This red line, that's where this more sensitive viral load testing algorithm found the infection. So all of these 4, right, the red line is at 0 because it turns out that they were infected at baseline, right? These green lines are Cabotegravir injections. So a lot of these people went on to get injections, even though they were HIV infected, because the site testing didn't find it, right? So what I'm going to show you up here are viral loads. So here, if we had done a viral load at the entry visit, it was 4,000. This person never would have been given a PrEP agent. They would have been referred to care. But that's not the standard of care algorithm. So nobody knew to do it, right? But look what happens as they go on Cabotegravir by itself. That's a single HIV drug. It goes to undetectable. And then even here, when the site finds it on their testing, it's only 78. And look, like the next time they check it again, it's undetectable again. So Cabotegravir by itself, just oral, suppresses your viral load really well. Briefly, we'll come back to that. And it makes your diagnostics much harder to use. Let's look at A2, okay? So this person's really infected at baseline. 50,000 is their viral load. That's no fooling. That wasn't found by the site-based testing. Again, who knew, right? This is new biology. This is being defined by this study. They take their Cabotegravir, their oral drug. It's pretty good. Look what happens to the viral load. It goes down to 204 just by Cabotegravir. And in fact, they get an injection of Cabotegravir. Happily, the site finally finds the infection here when the viral load is 1,600. Okay, but what I'm going to show you in a second is it's too late. What do I mean by too late? This virus is already integrase inhibitor resistant. You couldn't use one of our choice integrase-based first-line regimens with this. That's a problem. Hold that thought. A3 and A4, I'm going to kind of skip over because there's not a whole lot exciting here that's different than the other 2, right? Someone's infected at baseline with viral loads of 1,000 or 44,000. Look at how potent Cabotegravir even pills are. Suppress the viral loads to less than 40. That's impressive. Again, thank God the site finally catches it and starts them on antiretroviral therapy, okay? But what I want you to see here is, whoops, I zipped through some stuff here, is these numbers won't mean a lot to you unless you're a laboratory person who studies genotypic resistance, but these are integrase resistant mutations that seem to have come up when the person broke through the Cabotegravir. So that's really important. Okay, so let me, because we're running out of time and I want to leave for questions, quickly go through the others. So group B, these are the people who got HIV after a long break after any Cabotegravir. Okay, so the only thing I want you to know here is people weren't taking Cabotegravir when they got their HIV, and they didn't take any Truvada to cover their tail. I know many of you who've been thinking about this have been hearing me and others worry about if you get HIV during the tail, what does that mean for resistance? And the answer is nothing. We have 3 cases here of people who got HIV during the tail, and their HIV was not resistant to integrase inhibitors. Really important observation. It doesn't mean it can't happen, but in these 3 cases, it didn't happen. Okay, make sense? Okay, I'm going to skip to the C cases. Anybody who wants to look at these in more detail, I'll be happy to look at them with you. But the group C cases, these were people who got infected during the oral period. Okay, what I want you to look at right away is this C2 person. Look at these orange dots. They never took any oral drug. Again, can't expect someone to have PrEP activity if they don't take it. So let's forget this situation because it doesn't really tell us anything, right? But C1 and C2, again, check this out, okay? So orange dots, they took their oral drug. Turns out that they were infected here at week 4. Nobody knew that. They got 2 injections of Cabotegravir. Look at their viral loads. It's undetectable or like 100. Then it pops up to the thousands here. I'll tell you right now, that's integrase resistant virus. C3, same thing. Takes oral drug. Actually, the infection is detected 2 weeks in, super early, gets an injection. Look at the viral load, goes to undetectable, but then breaks through to super high levels, also integrase resistant virus. Could not respond to first-line treatment with integrase inhibitors. Okay, so again, only if you're a laboratory person do you care what these numbers mean, but I'm telling you that these mean that they were integrase resistant viruses here. And finally, the 4 cases of people who got infection despite on-time injections, these are all super interesting. So here we have somebody who took their oral drug, they got their injections on time, and they were a PrEP breakthrough anyway. Look at these viral loads, super low. But that's because Cabotegravir is suppressing them. And we don't know if there was resistance or not, because happily, as soon as the site found it, they started them on antiretroviral therapy and they suppressed. So that's good. This D2 case, super complicated. This was in Latin America. Again, the testing is really difficult to interpret. They don't get a viral load that's reactive until all the way out here, 75 weeks after enrollment. This person doesn't actually believe that they're HIV infected. And so they actually go on 28 days here of PrEP because they don't believe their HIV diagnosis. So these diagnostics make it hard enough that the individual in the study did not believe the results. So that's kind of crazy. I will tell you that as the Cabotegravir washed out of their system here at the end, they did ultimately get a viral load that was detectable and they went on treatment and they're doing fine. But that's kind of scary. D3, sort of the same idea, except the consequence here is we didn't get this person on treatment quickly enough, integrase resistant virus. And same thing with this D4 case, but this is a really, really depressing tale because this person gets diagnosed and their viral load is low, but it takes the site. This is in not the US. I won't get more specific than that. There's a non-US site. It takes 3 months for the site to navigate this participant who is known to be living with HIV to the National HIV Treatment Program. And by the time they get there 3 months later, they have integrase resistant virus. I worry that because our diagnostics are not good enough and our systems aren't good enough at getting people on treatment quickly, that this allowed integrase resistance to develop in this participant. So I think with cabotegravir PrEP, getting people on treatment as soon as possible after we find the infection is going to be even more critical than it is in more well-resourced settings. Okay, so these are our key findings. So this viral load-based testing found infection earlier than the regular testing algorithm in many cases, but the viral loads are low and sometimes undetectable. There's a prolonged period of this smoldering low-level viremia that we need to find, and because we think it will minimize the chance of resistance. These conventional antibody-based tests are diminished and delayed in many of the cases, and the testing can flicker. It can become positive and negative. As I mentioned earlier, I told you the punchline already. This is the resistance and the pharmacokinetics of the Truvada seroconversions, the 39 incident and the 3 prevalent cases. And the bottom line here is E16 and E34, and I'll blow them up for you on the next slide, are the ones that happened because that are the only ones that are not explained by non-adherence. So the blue dots that are solid here are plasma tenofovir levels. The blue open circles are intraerythrocytic tenofovir diphosphate blood spot levels. And this person, you can see, was taking their Truvada really well, and they got HIV anyway. And the reason they got it is they had Truvada resistant virus, full stop. It's a rare thing, but it does happen. There have been published cases of this. And this guy, E34, I don't really know what's happening because we were missing a dried blood spot sample from near the time that they were diagnosed. Their plasma concentrations look like they were taking it pretty well, but I can't tell you for sure. And their viral load was too low for me to get a resistance test. So I don't know if it was resistant virus. So anyway, what do we know? What are the key conclusions? Right here. So these 4 incident infections that basically were breakthrough despite people getting their on-time injections, I don't know why they happened. It's not because of low cabotegravir levels. And the good news is they're rare. They're rare events. But unlike with Truvada, where it fails, either if you get resistant virus or you don't take it, we don't fully understand the very rare cases why cabotegravir failed in this situation now. When you do break through cabotegravir at good concentrations, you can get integrase resistance. That's really important, and that limits your treatment options in a lot of these cases. Truvada, if you don't take it, if it does, it doesn't work. So what are we doing? This study is now in an open label extension. We're continuing this extension. We're making the oral lead-in optional for all the reasons that I mentioned: period of vulnerability in people who have trouble adhering to pills, onset of protection, no safety signal. We're using viral load testing as a primary screening tool at every visit going forward to see if we can identify incident infection earlier and prevent resistance. And we need to get people navigated to ART quickly on CAB if we're using it for PrEP. Let me just conclude by telling you that this is applicable as well to cisgender women. Our sister study, Oa3, same study design, sub-Saharan Africa, had a 90% reduction in CAB infections incident compared to Truvada in cisgender women. And so there is a regulatory submission going forward for all populations that were studied that hopefully will lead to regulatory approvals in the US before the end of calendar 2021. So that's the final image I will leave you with. So now we're at PrEP 3.0 because we had Aspire, the Ring, we had Discover, and now we have people twerking, getting injections in their butts with good incidence rates as well. And there are other injectable drugs coming down the line. I'll stop there because I do want to leave some time for questions and discussion. And I thank our sponsors and our participants and you all for your attention today.
Thanks, Rafi. That was brilliant. You're brilliant. I appreciate this hard work. You've made change in the world, and thanks for doing all the things you do. There are several questions here, and I just want to kind of group them together, so I apologize. but one has to do with the resistance issue. The question is, before you begin cabotegravir, do you recommend using an RNA test before bringing somebody onto this?
Yeah, great question. So we did RNA testing within 14 days of enrollment on every one of these participants. So the take-home lesson here for me is when you have people who are at extraordinarily high risk for HIV, that's not enough. You can't just do it and say, I have a result within the last 7 or 14 days before starting PrEP. You need to actually send one on the day you start PrEP. You don't have to wait for them to start to get that result. But when you get that result back, then you can get them navigated onto a fully suppressive regimen as quickly as possible. And I think my personal feeling where this is going is the same way a lot of sites have reversed their syphilis testing algorithm, to look for a treponemal specific test and then go back and do non-specific testing with titers, that we're going to start using more sensitive testing up front. So viral load testing, and then go back and confirm it with other more conventional antibody-based tests. And it's going to really push the field to develop cheap, implementable point-of-care viral load diagnostics in a way that we've not seen prioritized to date. And Linda Gale Becker, from Cape Town, said it beautifully. She said, if we can develop a COVID-19 vaccine in a year, why the heck can't we develop and prioritize these sensitive diagnostics before cabotegravir rolls out? Because this isn't just going to be a cabotegravir problem, right? All these long-acting agents, the monoclonals, islatravir, lenacapavir, all the other drugs in the pipeline, they're going to have this problem too. So this is the canary in the coal mine of what we need to advocate for and demand as we move forward with PrEP.
We have a participant from Zambia who asked the question, CAB is clearly a great way to go with long plasma concentration. Can you comment on, say, poor resourced areas on the planet, say sub-Saharan Africa, not South Africa? What would you recommend for baseline screening? Clearly this as a treatment for prevention, but also as a treatment, the long-acting injectables address structural, systemic, cultural barriers that exist as well. So can you comment a little bit about how you would use this in a resource-limited setting?
Yeah, it's a great question, and I wish I had the answers to that. I will preface this by saying there has to be the political will and the capital support to figure that out. And that needs to be a priority because this is coming and we need to figure out how to make sure this doesn't exacerbate disparities. And this can't be something that is just available to well-resourced settings. That would be a tragedy. And I fear, as I think we all fear, that we said that about COVID vaccines, and that's exactly what we're seeing with COVID vaccines. We're saying that, we're screaming, we're stamping our feet, and we need to demand that this not be a repeat of these other situations. We keep saying we're going to learn from the Truvada experience, and then we don't. Because what is clear is we need cheap, implementable, well supply chain resourced and supported point of care diagnostics. And that's going to be true both for ART treatment programs to diagnose failure, virologic failure more quickly and improve treatment outcomes as treatment programs are scaled up, but also for these long-acting PrEP agents that have the potential to be transformative. We just have to have the political will and the capital investment to make it so.
Great. One final question, and I apologize to everyone who wrote such great questions because there's some really cool stuff. We'll continue on this conversation later, but thinking about the transgender agenda, can you speak just a little bit about cabotegravir as some of the biology here about what to do in terms of the buildup? There's better protection for rectal sex, but less maybe for frontal whole sex? Can you comment on that? And also, what sorts of plans are there for trans men in future studies?
Yeah, so all great questions. Let me try to disambiguate those questions because I think they're separate issues. So we haven't had a chance to delve down into the kind of sex that our trans participants had yet and break it out between who had frontal sex, who was only reporting rectal sex. So I don't know that yet. I will tell you that Cabotegravir does not get into rectal tissue very well. It actually gets into cervicovaginal tissue twice as well as rectal tissue. So it's almost the opposite on a log scale of Truvada. And that may be why it was 90% protective for, 90% better for women and 70% better in our study. We don't fully know the answer yet, but whoever asked the question, thank you. We know virtually nothing about how well any of these PrEP drugs get into neovaginal tissues, which is usually scrotal tissue, sometimes intestinal tissue, sometimes neobladder tissue. And so we do not know nearly enough about that. And so there's no data to guide us, and we desperately need it. The question about trans men is a really important one. We could not include trans men in the Oa3 study because individuals born male have different pharmacokinetics than individuals born female. So the data were not mature enough to include individuals born female in Oa3 when we started it. It was sort of a complicated decision on the part of the Oa4 team to not include trans men in that study where they could have. And instead, I believe ViiV is planning a separate study for, by, and about transgender individuals that will also incorporate alternative injection sites, which might include the anterior thigh. So individuals who have had gluteal implants or fillers will be able to participate, because we had to exclude a lot of our transgender female participants, particularly from Asia and Latin America, who had had those cosmetic procedures.
Great. Well, thank you, Rafi. This is a knock 'em to the back of the theater presentation. Great way to restart HIV Grand Rounds. Great to call you my colleague and my friend. And thanks to everyone who was so good in offering all these questions. We'll see you next month.
Thanks, everyone.